very common domain of all of you who are senior trauma people. But then what all things have changed into that is what we will be focusing. And again, as I am saying all the time, let's make it interactive. So the first is going to be 6 or 7 small presentations. One onto lateral malleolus, isolated lateral malleolus. The second would be onto posterior malleolus, then syndesmosis, then some special situations in ankle fracture and diabetic ankle fracture. So, uh, are you all seeing my screen?
Yes, sir.
And am I audible? Perfect.
Yes, sir. Very much.
So, okay, thank you. Uh, so, management of isolated lateral malleolus fracture. So, 23 years old male had a fall and closed injury. Anybody? Obviously, this is a session onto the lateral malleolus fracture. So, obviously, we are going to talk about lateral malleolus fracture. So, this is a case with a closed lateral malleolar fracture. And this is how he was treated in a plaster. And this was 10 days. Anybody?
Sir, the screen is not shared, sir.
I am sorry?
The screen is not shared, sir.
Screen is not shared, sir.
Don't tell me. Uh, mm, mm, just a minute. Okay. Mm. So now is my screen seen visible?
Yes, sir. Now it's
Yes,
clear.
sir. Yes, sir. Now it's
Okay, thank you. Uh, okay, so management of isolated lateral malleolus fractures. So this was a male of 21 years, fall and closed injury. And this is how he was treated. It was 10 days in a plaster that he comes to you. Uh, how would you go ahead? Anybody, please?
we will take a stress X-ray.
Okay. So you feel this is stable or unstable?
This is
Sir, it is
Unstable,
unstable.
sir. Unstable.
Syndesmosis is already open. So would you be just going for stretch X-ray or straight away going for fixation?
Perfect. So this is how he comes, and then the question is, can this be treated in the cast? And as you all said, this cannot be treated in the cast. So uh, you all said that the stable versus unstable fracture of lateral malleolus, how would you decide? And that is by the stress X-ray. We did discuss it when we talked about the uh, gravity stress view in the radiology. So as you all know, ankle is considered as a ring. One fracture, that is fibular fracture. If you have a stable anchor mortise, then it's all right. But if there is a ligament disruption, it becomes an unstable anchor mortise fracture. So this is what we were taught: medial swelling, medial ecchymosis, medial tenderness, That means unstable lateral malleolar injury and fixation would be a must. But as you all said, gravity stress views are required to decide about stability of a lateral malleolar fracture. So how do you take it? I've shown it. You ask patient to come down, and the limb should be hanging from the edge of the table. The limb is externally rotated and a cross table view is taken like this, and this video essentially demonstrates this cross table view, and this cross table view is going to tell you this is how you see a cross table view in a normal uh, imaging. But if this is the EPX, this is the gravity stress view where a stable looking lateral malleolar fracture got displaced. So this to us looks stable, but then when you take a gravity stress view, this is an unstable. So suppose this is the situation now, considering this fracture for you to treat, how would you treat anybody, please?
Sir, we would take a posterolateral approach and go between the plane of peronei and flexor muscles, and we would I would fix it with a plate and also put one screw for syndesmosis, which would be 30 degrees postero anterior in the coronal plane.
Okay, so you'll put in a posterior plate. Somebody may like to put in a lateral plate and put in a syndesmotic screw. Both may be perfectly okay. Right.
Yes, sir. Lateral plate and syndesmotic screw.
So medial examination is a poor predictor. We need to do gravity stress X-rays or manual external rotation stress X-ray, or like this where you're holding ankle in a plantigrade position and externally rotate the foot to stress the deltoid ligament, and you take a mortise view. And if these two are non-conclusive, then you give a plaster to your patient, ask him to walk, let him have trial of weight bearing for 10 days and reassess with the x-ray. If the fracture displaces, that means that patient requires fixation of a lateral malleolus fracture. So medial examination, gravity stress x-rays, manual external rotation stress test, and trial of weight bearing for 10 days. This is what you require to do. Suppose this is unstable, then you're going to go ahead with fixation and doing a syndesmotic fixation. Now,
Excuse me,
this
sir.
was, yeah, please.
Sir, you said about trial of weight bearing. Sir, should this weight bearing be in a cast?
Yes, in a cast. So you give a weight bearing cast to the patient. This is what I've done many a times when it is a dicey situation. You give a weight bearing cast and then ask the patient to walk over it. And then if the lateral malleolus fracture displaces, that means it's an unstable variety. You need to go in and fix it. Now
Sir,
this,
after 10 days, sorry, sir.
yeah,
Sir, after 10 days, would you take the plaster off and get gravity stress views or just
no,
standard
no,
weight bearing X-ray?
standard view through the plaster. Because you've given a plaster, it was a well aligned fracture in the plaster. When patient started weight bearing, it would be the ligaments which will come into action. So you ought to note whether it has displaced or not. That's what I've been doing many a times in many of my patients where it is not, it is dicey. I tell patient that okay, we'll give you a plaster, we'll take a x-ray. If it displaces, then we'll go ahead and we do the fixes. Now coming back to our case, so he came to us with a plaster. We removed the plaster and gravity stress view was taken. Any comments onto this?
So the medial clear space is increased.
So now would you fix or would you treat conservatively?
Fix it, sir.
Fix it, sir.
And obviously you will need a plate and a syndesmotic fixation. So this is what was done. It was like 6 weeks post-operative, and suture anchor was pushed. Any comments onto this fixation? Will it stay or will it fall apart?
It will fall apart, sir.
This
It
will
will
fall
fall.
apart.
Because
The
syndesmosis
syndesmosis is
at very
quite
higher
high.
side,
Yes, sir.
quite high.
Yeah.
Oh,
And the
So
joint
the
is not reduced.
fibular, so the fibular anatomy, that's the length and the rotation has not been restored.
not been restored. Right. So sometimes you feel that this is what one study came in, that are we overdiagnosing instability by the use of gravity stress testing? So not that gravity stress testing always works well. So you have to have multiple other this thing, a medial examination, a stress examination. Sometimes gravity stress X-ray gives you a wrong impression. So there is a study where they always said that you always compare it with the opposite side. So from this, a simple take-home message which I wanted to give, and we all know about it, that clinically you assess for the medial ankle pain, tenderness. If still you are in doubt, do stress test, right? And not that herein only thing would be a syndesmotic injury. There could even be deltoid injury. So mind you that the uh, widening of the space cannot only be because of the syndesmotic injury, even it could be because of the deltoid injury. And gravity test, manual acceleration test, and then stable fracture is amenable to non-operative treatment. Unstable fracture, you have to go in and operate. So this was a short uh, slide presentation, which all of you know, fortunately. Uh, Anything anybody wants to comment or anybody wants to
Sir,
say?
in these cases, when should we repair deltoid ligament?
Okay, so just be patient because there is something which I'm going to talk about very soon.
Sir,
It's a hot cake today in foot and ankle orthopedics, deltoid injuries, deltoid repair, deltoid reconstruction. It's a hot cake. And pendulum is gradually shifting towards management of deltoid in the form of surgical management. So we will discuss it going forward. Is that okay?
Excuse me, sir.
sir,
Yes, sir.
Yeah, please.
Sir, what is the role of Weber classification these days about fibula fractures? Or should we just consider stable and
So the bottom line is that as Paul Tornado, who spent whole his life into working on syndesmosis, that don't consider any fracture as a stable fracture. Have a high index of suspicion. Stress every fracture. Stress ankle at every juncture, and you may find surprises. Okay,
sir,
is
I
there
have a
any
doubt.
advantage? That's a great question. Is there any advantage of
Sir, I have
anatomical
a doubt.
fibular plate
Yes, sir, I have a doubt.
vis-a-vis a simple fibular
So
plate?
in such a seemingly stable, undisplaced fracture, why can't we go for a conservative treatment for 6 weeks? And then if the serial X-rays show, that means not these stress X-rays, but the regular X-rays. If they are not showing any displacement, is there any role of a conservative treatment?
Oh, that's a great question. No, yes, you could try conservative treatment, but then you will have to monitor it continuously with every weekly check X-rays. Every weekly check X-rays. And if it opens, if it displaces, then I think we will have to go in and do something. So very rarely your patient may not agree. Sometimes we tell them that you need to fix, and then some other doctor has seen and said, no, this doesn't require, this requires a plaster. So if at all you are forced to treat, I mean, by choice, you should try to uh,
That exactly
fix
was
it.
my doubt, sir. Because sometimes any litigation or a medical jousting can happen, whereby the other doctor can told this could have been treated in a plaster. That's what I was actually asking.
Yeah, but then you have your gravity stress view. You have
Yes,
your,
sir.
yeah, X-ray records, so you can definitely prove it. So
Thanks, sir.
if you're treating conservatively in today's era, I think you can go haywire. There is a great question somebody has asked. Yeah, I think Dr. Call has asked. So, any advantage of anatomical fibular plate vis-a-vis a simple tubular plate? Uh, well, all anatomical plates, they you do need to slightly contour them. This is what is my opinion, and this is what is my observation. So sometimes they, when they do not fit well, they create some angulation onto the fracture. The advantage of the anatomical fibular plate is in the distal fragment you get so many screws, while in a semitubular plate you may not get those many options. So that is the only advantage, and that's why anatomical fibular plate is to be used. But you be aware sometimes they uh, ought to angulate your fracture. There is one more question in the chat. What is your tips for putting syndesmotic screw in case of comminuted distal fibular fracture? Yeah, so comminuted distal fibular fracture, sometimes you are really not having a window of opportunity to put the syndesmotic screw from the area where you want to put it. So in such kind of cases, though we do not like to prefer, we don't like to go ahead and put in a screw through the distal fragment. We like to put in a screw only through the proximal fragment. Sometimes you may have to put a higher screw and a screw closer to the syndesmosis. Normally, transsyndesmotic screw is not preferred, but then still there are surgeons who prefer transsyndesmotic screw. So sometimes if you are forced to pass, if you have a comminuted situation, you do not have any go, you may think of passing a transsyndesmotic screw in, and if you have access to tightrope, your patient is able to afford, you can use that. Is hook or cotton test to be done before deciding on to before deciding? Okay, yeah. Deciding and okay, screw 3 or 4 screws, routine removal after 3 months. Okay, so just the next presentation after this presentation is on syndesmosis. How many screws in distal fragment, and do you use always locking screws? Oh, that's a great question. But you see, at least in a distal fragment, if I have because they are all locking screw, at least 4 to 5 screws is what you would prefer, and most of them are locking screw unless you have an opportunity where you can also put in compression screw in a distal fragment. Synthesis plate has got that facility, so you can put in a one screw provided you are at the level where you're not going to injure anything else. You're not going to go past your fibular articular surface on a medial side. The thickness of plate in anatomical plate and cemental plate is quite different. Yeah. Does that matter? Uh, not, not really. In an osteoporotic patient, definitely you would like to have maximum purchase points. So you would like to use a locking plate. No question about it. Thickness is not a big issue. Uh, Unless you're putting a posterior plate, you are little worried about the thickness. But now these plates, they come into good kind of uh, thickness, so you should not be worried about. Yes, there is a role of rust nail in fracture fibula, so we're going to discuss that. When do you use the nail? Nails, interlocking nail for fibula, which is not available in India, have come in a big way in US, and they are different nails. We are talking about the rust nails, but then this interlocking nails have a facility through which you can pass the syndesmotic screws also. So they're more anatomical, more rigid, more doctor and patient friendly. So we're going to talk about this interlocking nail for fibula. Till that time, rust nail in fibula, I think it cannot control the rotation, and sometimes in a comminuted situation, not the shortening. So it is, I mean, it is slowly going away. When do you start weight bearing in these fractures? Oh, that's again a good question. So mind you that you are dealing with not only bony injury but the ligamentous injury, and bone heals with the bone. Ligaments takes long time to heal, they heal with fibrosis. So uh, there are cases where people have removed the syndesmotic screw and then syndesmosis is again opened. So at least weight bearing not before 8 weeks. This is what the dictum I have followed. And if it's an isolated fracture, of fibula without the syndesmotic injury, you may start weight bearing little earlier, 2 weeks or so. Role of TENS in the fibular fracture. So that is what I said. Role of Rusnell, TENS is slowly, steadily going on. It is when you have a short oblique or a transverse fracture in a pilon kind of a situation, you may like to put in a 10 nail or a Rusnell, where or a tibia fracture, it is lower third, and the fibular fracture is at the level of the tibia, you may like to stabilize with the nail. Any role of CCS for lateral? What do you mean by CCS? Santosh?
Corticocancellous screws.
Corticocancellous screws. Okay. So, this screw, you will have to be very much watchful when you pass it from the tip. There are 2-3 reasons that sometimes if they not pass in the proper direction, they go intramedullary, which do not have much rotational control. Second thing, if you want to pass to the opposite cortex, if the proper direction is not there, then the fibular fracture can displace. And the third, when you are passing this screw, you have to be watchful that you are not damaging ATFL or calcaneofibular ligaments origin. So you can use it for a low level, I mean a Weber E type of this thing. I'm going to show you a case where I've used cannulated cancel screws, but uh, you will have to be watchful. Are there any parameters intraoperative that you would check on C-arm to know that fibula plate is perfect? Uh, Not really, but yes, you want to check it. You can, by your eyeballing, by visual impression, you can check it. You can put in a two blocking towers over the fibula and put in a small K wires, hold the plate, and you may check it. Only thing that many times the distal fragment is into external rotation. So the plate you have to put may not be exactly the kind of plate when you reduce everything you're going to see. Because you have to put in the distal plate, you have to put in the plate into the distal fragment which will go in a slightly externally rotated position. And then when you align it, it will come into the place. So every time it may not be possible, but yes, you always, when you put in a plate, you always see the AP and the lateral view of the fibula and how plate sits over it. How can one prevent disuse atrophy of bone in delayed weight bearing? So you see, you're not allowing them weight bearing, but at the end of 4 weeks, you start your ankle foot range of motion strengthening exercises. So that regains the tone into the muscle. So unless you're stabilizing, unless you're putting them into a plaster, then demineralization would occur. But if you are allowing them to do, ankle pumps and ankle range of motion, I don't think there would be any disuse atrophy. If there is a distal fibula fracture with tibia shaft fracture, similarly stable fibula with medial malus, intermediate cava rusted, can be used if it's a short oblique fracture. If it is stable fracture, you can use a rust nail or a 10 nail. We all, have been using it. Do we need to open reduce syndesmosis to confirm? Chalo, that is a syndesmotic part, and we'll
Till
definitely
what
discuss that.
length from the ankle do you fix the fibula, sir? Usually we were taught like 5 centimeters from the ankle joint that we need to fix the fibula. Is there any
So I think for us, at least in a proximal fragment, six cortices in a proximal fragment. 6 cortices. Now with this plate where you have a hole through which you pass the syndesmotic screw, you may have even to choose a little longer plate. But 6 cortices into the proximal fragment is what uh, we will
Sir,
all do
sir,
it.
I think the question is
my
up
question
to
was
what
from
length of fibula?
yeah.
Up to
So
what
from the
length of
ankle
fibula do we
joint,
need fixation?
Okay, length of fibula above the ankle joint.
yes.
Yeah, so it all depends. I don't think there is a thumb rule which I follow, because sometimes you have a combination and you also want to pass a syndesmotic screw. So whether there is a syndesmotic injury or not, it depends onto that. Otherwise, for routine one, yes, 3 cortices above the level of fracture into the proximal fragment is what you want. So 6 cortices or 3 screws. So that should be the minimum length. Obviously, when there is a syndesmotic injury, two screw holes will be added through which you want to pass this in. So then the plate would be longer. But
So, I mean, what is the definition of lateral malleolus? Like, do we define it from ankle length above 5 centimeters? That is where we fix.
I am not aware about all these things.
Okay.
For me, it is a fracture, the level of the lateral malleolus fracture. If it is at the level of the ankle, yes, it is something which is uh, at or below, we call it Weber A. And if it is at the level of ankle mortise and uh, something like uh, 2-3 centimeters up to the level of cinder, it is like Weber B, and above that it is Weber C. But
Okay.
I am not aware about any fix. It may be there, but I am not aware about it.
Okay.
Sorry. So,
Excuse me, sir. Sorry to
please,
disturb, sir.
please.
I think because we are talking about the high fibula fractures here, sir. What if it is a Mason's injury? The medial malleolus is gone, and there is a proximal fibula fracture, but that fracture is causing decrease in the length of the fibula at the level of ankle. So, would do we fixing those fractures as well to bring the fibula down?
Absolutely, absolutely, absolutely. So, if you have a Masonier injury, it is not necessary to go very high up into a zone where you can injure the lateral popliteal. So that is not required. But these fractures, the syndesmosis is vertically unstable. So that is very, very important. So you want to restore the length of the fibula. So either you, when it is like uh, in the level of fixes and you could fix it, go ahead, put in a plate and fix the fibular fracture. And you may put in a plate below that plate through which you fix up the syndesmosis. If it is very high up at the level of the proximal third of tibia where you cannot really go and fix it, you put in such a plate that it is fixing the syndesmosis. So through the plate you fix the syndesmosis. If it is a fracture which is amenable for plate fixation, either you can use a long plate and last two screws would be syndesmotic screw, or you use two plates and the last plate, the lowermost plate, is fixing the syndesmosis. I hope I
So,
am
sir, so you
clear.
mean to, yes, I understood, sir. So you mean that when we are fixing the syndesmosis, we should always use a plate. Maybe it's a two-hole plate, but the syndesmosis should be fixed through the plate.
So when you are fixing syndesmosis, uh, in such cases where it's a Weber C and you're fixing it, the fibula is such a small thin bone that when you pass a drill and then a screw, which you may use 3.5, I do not know what is your preference. My preference is 3.5. Somebody may like to use 4.5. So it can fracture the fibula and it becomes a weak link into fibula. That is what people came up with multiple studies. And so it was advisable and advised that you put in a plate and pass the screw through the plate, which makes it a strong construct and fibula will not fracture. Again, when you are putting a plate, where would you pass this syndesmotic screw? Anybody? And why? Suppose it's a Weber C Masonier kind of injury and you are putting a plate and through the plate you are passing a syndesmotic screw. So in that case,
The distalmost screws of the plate.
I distal most or the centermost, but you will leave the uppermost screw. And sometimes, if it is a pure syndesmotic injury, I like to pass screws from the central two holes, the uppermost and lowermost we leave. Again, it depends where you are putting your plate, but in a pure syndesmotic screw injury or in a Weber C kind of injury, you have your choice to put in the plate where you want to put in a syndesmotic screw, which will go between 2.5 to 4.5 centimeter of ankle mortise.
Now, sir, other thing is like talking about the Mason's injuries. Like I have had one or two cases in which the fibula was high fibula, but it was very hard to bring the fibula back to length. How to bring fibula back to length when we are the fracture is in the danger zone and the ankle motor.
Yeah. So in that case, you have to put in a push-pull screw, and you may have to osteotomize the fibula. You may have to create a fracture, another fracture at a lower level, and put in a screw which would go above the area of the fracture. Fix your plate into the distal fragment, then a screw is put in proximal to the plate, and then you are putting a laminar spreader and you are getting the length of the fibula. You're getting my point. You will have to create one more Faber C type of a fracture, fix your plate
Okay, sir.
and get the length, because this vertically unstable, this is the only injury which is vertically unstable. Other syndesmotic injury, we see it that it is going out and in, or it is going into the sagittal plane. This is the one where it goes into the vertical plane. So bringing the length of the fibula is very important.
Thank
So
you, sir.
should we move to this management of fractures of osteomalus? So the question is, why should we talk about osteomalus? What is that which requires us to talk about osteomalus? But before that, before I open this talk, now this is an open question. Should you fix this osteomalus fracture or not? And why and how?
So this needs a fixation, but to confirm the fixation, I need an anteroposterior view as well as a stress view. And the method of my fixation will be putting a buttress plate and a screw through the plate.
Yeah, I absolutely agree. Would want a CT scan, all this, but just question that this is a very small fragment. Would you like to fix it or would you leave it?
Yes, so
Uh,
the present criteria, the old criteria of 25% is not valid nowadays.
yeah,
Irrespective of the fragment, the PITFL will be insured, so that needs a fixation.
okay. So you're almost there into the answer which I wanted, but anybody knows about some classification uh, which has given this?
Sir, there's Barton's
Which is
in 2015,
Great.
which is based on the axial sections, the incisional notch.
I think you're so much informed people that, I don't know what I'm really going to talk to you people, but it's absolutely right. It's absolutely right. See, that classification told us that the smaller the fragment, more is the unstable situation. So please remember this. Smaller the fragment, more is the unstable situation. We are just going to see few slides into which I'm going to show you that presentation, where the fragment has got this small fragment will have attachment of PITFL, posterior inferior tibiofibular syndesmotic ligament, and if you don't fix it, it would fall apart. Now, approach for fixing this kind of a fracture. This kind of a fracture, say anybody, I mean, this is all arbitrary situation, but then if there is such kind of a fracture, uh,
sir, this is a fracture which would require both approaches, a medial and a lateral approach.
so medial or posteromedial.
Posteromedial and a posterolateral
So
approach.
Dr. Tanay,
Haraguchi type 3. Ji,
yeah,
sir.
yeah, Dr. Tanay. So which position you would put your patient into?
Prone, sir.
Prone.
Prone. Anybody for some different approach for this?
Floppy
Okay,
lateral.
floppy lateral. Okay, no, but you want to go for posteromedial, posterolateral, floppy
Sir, I
lateral.
would prefer posterolateral approach only. See, if I can see definitely the fracture line through posterolateral approach. And if I see fracture line and if I can reduce it, I don't have to resort to posteromedial approach.
Okay, so there's two things we're going to come up in this presentation. And Dr. Tanay, once we finish this session, I would call you for some of your query. Sorry, I just
Yes.
could not do that today.
Thank you, sir. Thank you, sir.
So then question comes, why talk about osteomalus fracture? We all know it forms a part of incisura. And a strong PITFL gets attached to it. So that's why we're talking about posterior malleus fracture. It's very important for syndesmotic stability. If you fix it, 70% of the cases you don't have to fix the syndesmotic screw or a tight rope, because it automatically restores the stability of the syndesmosis. Now, such a case where you have a female of 34, young female, road traffic accident, closed injury, you all know that there is a posterior malleus fracture, just something like that. But here comes my question to all of you. Which all are the X-rays you routinely get for your ankle fracture cases? Dr. Prabnur, what are X-rays you get?
Sir, we would go for sir, I go for AP, mortis, and lateral. And like in such situations, I would not be much worried about the X-rays because I will be anyways planning for a CT.
No, but say suppose you are out and your X-ray technician and your staff, says the ankle fracture, say trimalleolar ankle fracture. Which all X-rays you would ask them to, you would be having a protocol in your hospital. So which all X-rays you would ask? So you would ask them to take AP, oblique, and lateral. Anybody disagrees with
Yes.
him? Anybody wants to add something?
Maybe a knee X-ray as well. In most time, I asked whether there is tenderness on the proximal
Yes.
end of the fibula.
So AP, mortise, lateral, and you also need joint above, so knee with leg. I like to add two more views into this, and more so for cases where it's a bad ankle injury, time alone. Any guess? Any more views? X-ray, yes, CT scan we all are going, but we have doctors for whom getting a CT scan into their area may be difficult, maybe patients may not be affording. So not that always CT scan is possible. Uh,
Ankle oblique view?
Internal oblique
yeah,
and
so
Oblique view?
we have ankle AP, lateral, mortise is internal oblique view.
Foot
And
X-ray.
no, we're talking about
Sir,
ankle.
opposite limb, opposite ankle.
Stress views.
Stress views, this is the view I almost always get. Lateral view in 40 to 50 degree of axial rotation. It is this view which clears the overlap of fibula, and you have a clear-cut idea of posterior malleus. And mind you, this is the view which you also require to see intraoperatively. If you have a situation where you have to do fibula first, then you feel that, oh, I am not able to see my posterior malleus reduction. This view is going to show you your posterior malleus completely. Irrespective of whether you do fibula first or posterior malleus first, this view is the view through which we monitor everything intraoperatively, and preoperatively I like to get this view. And okay, so coming back to this case, because there was a lot of swelling, so in emergency, reduction of the ankle dislocation and external fixation was done, and obviously you all would want CT scan. So CT scan, what would you do for this patient? What approach? Right. I lost
Posterolateral approach.
posterolateral approach, right? And then tell me, when you do posterolateral approach, do you put posterior plate or you also put in a lateral plate?
Sir, in this case, according to the fracture pattern, a posterior plate would be better. So the fracture pattern would decide the plate's position.
So,
and this would be a Haraguchi type 2. So a buttress plate, maybe a distal T plate or a distal radius plate would suffice here for
yeah,
posterior
for the
malleolus.
posterior malleus, right? But for the fibula, you would use a posterior plate.
Yes, sir.
Okay, so this is how it was done. So medial malleus was fixed like this. Any comments onto this, or is okay?
So use of only single
PA screw, posterior anterior, and when to use a single antero-posterior screw that we used to do few years back.
I I've almost stopped using antero-posterior screw. Posterior anterior screw, uh, very, very rarely. I would always like to buttress it with the plate. Sometimes I may not put in a screw. If it is small fragment, I just buttress it. But buttressing is more important. No posterior anterior screw would give you buttressing.
So which plates?
I have used lower and radius plate. I've used those all imported fancy plates. Sometimes I've reversed the lower and radius plate where you lose the advantage of putting the locking screw. But for me, I've seen that the absolutely reversing the lower and radius plate gives fantastic buttressing. It gives very great push. Uh, More so for a malunion posterior. When I do the osteotomy, I like to push it with the lower and radius plate, which is reversed. And if you see the lower and radius buttress plate, and when you reverse it, and when you put in a uh, 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 non-locking screw into the proximal fragment, it would solidly push the fragment together with the ankle anteriorly. I would give this tip to all of you that use it sometimes. It really
Sir,
gives.
may I interrupt? Reversing the plate means the T part is lower side or
No,
reversing?
no, no, no. I mean, this is how you're putting the plate.
Yes, sir.
Normally, you just reverse it. So all your locking holes and everything goes behind
Towards the plate. Okay. Yes.
towards
Okay,
the
got
plate.
it.
Yeah.
So Bowler buttress plate or T plate only?
The volar buttress plate. Volar buttress, obviously, Rowan radius.
So can we
So
use a one-third tubular plate?
yes, I've been using 1/3 tubular plate, but the problem is that the posterior is a wide, uh, uh, sometimes it's a wide piece, so only a semi-tubular plate may not be really able to uh, buttress it nicely. And sometimes you also like to put in some screws to that fragment. So if it is a plate which is like wide below, it will help you. So we want to talk about four important parts. One is classification, which is based on to CT scan, its relationship with syndesmosis. More often than not, prone position and posterior approaches are being used, and we have to forget that 25% or 33% rule, which somebody already pointed out. So there are two fragments, posteromedial and posterolateral. We know that, and this is very important. There is an sometimes intercalated fragment which are dislocated proximally and impacted under or into the posteromedial fragment. So now my question, how do you deal with such intercalated fragment? There are sometimes intercalated fragments under the posterolateral variety of posterior malleus. Have you seen this situation?
Yes, sir.
Yes. So how do you address this combination? Because you do reduction of posterior malleus indirectly. You do not have an access to, and you don't have to just strip off the PITFL to open the fracture. So your reduction is indirect. So how do you manage intercalated fragments which are between uh, posterolateral posterior malleus and some intercalated fragments here?
Sir, one should hinge out the lateral part either or the medial part either. Then achieve the reduction of the intercalated fragments. Fix it with K wire temporarily. Then that K wire can also be passed through the either medial part or the lateral part. If required, take out a graft from the proximal part of the TBI itself, support those intercalated fragments, and sandwich those intercalated fragments into one of the fragments, either medial or lateral, depending on the morphology of the fragments.
So this Pandey sir,
Yes, sir.
great. But what this trick is called? I mean,
No idea, sir.
no idea. So this trick was described by Weber. It is called as Weber's trick. So what Professor Weber did, he goes through the fibular fracture. You need to go through the fibular fracture, put in a lamina spreader or Hintermann distractor, and fall the and make sure that you fall your fibular fracture down, and through that window you approach your intercalator fragment, reduce it. Maybe you may put in a wire. Sometimes you may have to leave that wire as a lost wire, and then reduce it. So we will going forward, we will see some slide about it, that how to manage intercalated fragments with posterior malleus fracture. So the first classification we all know was by Professor Haraguchi. It was like type 1, type 2 and type 3. Uh, in the type 2 posteromedial ankle fracture, they demonstrated significantly poor outcome scores at 2 years follow-up compared to Haraguchi type 1 and type 3. This is what Professor Haraguchi came with in his classification. But he said that posterior malleolar fracture morphology determines the outcome in the rotational fracture. And he said that this also requires to be fixed with the buttress plate, this to be fixed with the posterolateral approach, this to be fixed with the dual approach. That is what he advocated. And then Clemmer's classification was posterior pilon classification, which was almost on the same line. But yes, you all said Ramel's classification. And then the last one is Masson's classification. So this was the Ramel's classification. But the most important part, which Batonix and Ramel said, that large posterior fragment means type 4-1, that means intact PITFL, and fixation of fracture fragment would stabilize syndesmosis. So this is the case where you may not need a syndesmotic fixation. But a small posterior fragment, probably torn PITFL, and syndesmotic reduction would be required for such cases. So a small fragment like that would require fixation, that is type 2 Ramelt, and a big fragment shown here may just require the fixation through uh, a plate, or someone was asking anteroposterior screws. In this case, uh, this is from the literature. He has used anteroposterior screws. And the last classification, the latest one, is that of Masson, where he said that type 2 involves posterolateral triangle of tibia or Walkman's area. And then this, he also gave an algorithm to manage this. What he said, that it is our normal practice to access and fix wherever possible the posterior fracture before fibular and middle malleolar fracture reduction. And then he showed that if you have a posteromedial, okay. Now, if you have a posteromedial and posterolateral both, which one would you fix first? Anybody?
Posteromedial first, so
Post
that
posterolateral.
No, I think Dr. Balu is absolutely right. That posteromedial should be fixed first, because if you fix posterolateral first, you will not be able to reduce the posteromedial. So it is the posteromedial which should be fixed first. And now this figure itself shows that if you fix this first, this will get displaced and you may not be able to reduce it. So the first thing you should be doing would be fixing posteromedial, then posterolateral. Okay. Now this is Masson's classification, which said that how to access the intercalated fragment. They said that intercalated fragments to be accessed through the fibula prior to fibular fixation, restoration of the tibial plafond with reduction or fixation of large intercalated fragment. Whereas Professor Deshpande said you could put in K wires and you could leave this K wire as a lost K wire. So this is how you access the intercalated fragments. So This is again lamina spreader into the fibular fracture, and you have displaced it, and this is the intercalated fragment removed outside as shown in this uh, uh, paper. So then in the same paper they've said about varieties of intercalated fragment. So there are three varieties of intercalated fragment. So this is the case 1, this is the case 2, this is the case 3, and look at the difference they have. So there were three types of intercalated fragment described. One in this classification by Mason, a position. So where this fragment is lying, at what part, is that near the incisura onto the posterolateral or posteromedial? So that is a position. B is the size, if it is less than 2 to 5 mm or more than 5 mm. And C is the shape of the intercalated fragment, if it is free, if it is folded, if it is compressed. And this is again through that article that you lift up the fibular fracture, put in a lamina spreader, and through the fibular fracture you reduce the intercalated fragment. Now,
Sir, excuse me,
so
sir.
yeah, please.
So would this mean that whenever we have this intercalated fragment, we should be doing these surgeries in a floppy lateral position rather than in a
No, this picture is in a prone position. You can do it in a prone position. Now, when you have intercalated fragment on posteromedial side, then you should be doing posteromedial first, then posterolateral. But when you have intercalated fragment in both, then again posteromedial, fibula, posterolateral. So you can do it in a prone position. There is no problem. And
So we are
whenever you
going
are,
through the fibula through the same approach,
yes,
posterolateral approach only, not a different approach for fibula.
not a different approach. And when you have a malunion of the posterior malleolus and that too posterolateral, and if the fragment is small, you have to go and do the osteotomy of fibula, and through the osteotomy of the fibula, you have to access the posteromedial malunion, malunion of posterior malleolus. So when there is a fracture, it's an automatic natural osteotomy for you. When there is malunion, you have to create an osteotomy of fibula and do the posterolateral reduction of posterolateral variety of posterior malleolus. Now, so everybody said about posteromedial approach and posterolateral approach. Any other approach you know of, posterior approach? Anybody? Anybody know of any other approach? Now, this approach which I am talking about today, that approach is a hot cake, and that is modified posteromedial approach. Anybody has heard about it?
No, sir.
No.
No,
So
sir. No, sir.
modified MPM is the approach which again in my practice I've started using a lot, and this is the approach which would not necessitate you to go in for posteromedial and posterolateral approach. With this single approach, you can access complete posterior part of TB. How? I'm going to show you. So when you have a posterolateral and posteromedial variety of posterior malleolus, you do this approach. So this article showed that we all know posteromedial. In fact, I showed you the video, the video of that approach, uh, which I took during my surgery. This is modified posteromedial, and this is posterolateral. We all know. Now let's talk about modified posteromedial. So three approaches to choose from depending on the shape of the posterior fragment. Now, if you have a posteromedial, you can go and do this approach. Modified posteromedial, when you have a posterolateral as well as posteromedial fragment plus some intercalated fragment, and you have a posterolateral and you use a posterolateral approach. So this is the kind of visualization you have when you see through the different approach. So this was a trans-sectional analysis done in the same article. Through the posteromedial, this is the amount of posterior part of tibia you see. Through the modified posteromedial, you could see everything, fibula and complete tibia. And posterolateral, you are able to see incisura, part of the fibula and the tibia. So this is the access you have with posterolateral. This is through the posteromedial, but this is the approach which gives you complete exposure. And I'm going to show you the drawing. Okay. So typically this approach is between the Achilles tendon and FHL, which goes medially, and vessels, flexor hallucis longus, flexor digitum longus, tibialis posterior, they go laterally. So when your patient is in the prone position, you're going between Achilles and FHL on one side and neurovasculars and tibialis posterior and FDL on other side. So there is a picture of this approach as we. So when you are approaching posterior malleus, you set your priority. Your priority is articular reduction. Your priority is length, rotation, alignment. Plan your fixation. Plan your approach. For approach, you have to consider the apex location of dominant fracture line and consider articular impaction and location of it. Obviously, you have to do careful soft tissue handling, but all those people who are taking this posterior approach, are they putting a drain? Dr. Prabno, Dr. Tanay,
No, sir.
Dr.
No,
Deshpande
sir.
sir?
No,
No.
sir.
Okay.
No, sir.
And Deshpande sir, have you ever noticed some problems of stiffness after posterior approach?
Yes, sir, I have. What happens, sir, is the posterior structures get attached if I don't start my mobilization early. Plus, I mean, the stiffness, of course, surgical stiffness.
Yeah. So this is one important no, I mean books do not mention this, but I also started using drain more so if I am doing a late case, revision case, and early mobilization for these cases by 3 to 4 weeks is very important. Otherwise, patients will get stiffness and a plantar flexion contracture. My friend John Cohn, whom I consider the master of foot and ankle trauma, uh, he has taken up a study where the cases where they go posteriorly, he beforehand only, after he finishes the surgery, he lengthens the tendoachilles by doing he lengthens the calf by doing gastrocnemius recession. And the cases, it's a one set of cases, he's doing a study, he's not doing gastrocnemius lengthening. Other set of cases, he's doing gastrocnemius lengthening. And he feels that because these cases do have some degree of plantar flexion contracture, why not beforehand release the tendoachilles? The study results are yet to come. But this is a thought-provoking idea that majority of these cases they do land up with some plantar flexion soft tissue contracture if you don't properly mobilize them. uh, Somebody feels and thinks that we should at the time of surgery we should lengthen the gastrocnemius. So posterior approaches with the prone position, and this is the posterolateral approach where you make two windows. One window is between the fibula and peroneal, other window is between the peroneal and FHL. So you all know this, I'm just going through it hurriedly. Prone or lateral position, midway between uh, tendoachilles and fibula. You have to save sural nerve, very important. Double window approach, FHL medially, peroneal laterally. You identify FHL by great toe flexion. Anybody, when you take posterolateral approach, how do you monitor your reduction? Anybody? because you're doing an indirect reduction.
Sir, image,
Hmm?
sir, CM.
Yes, Siam, but intraoperatively it will be the interdigitation of the fracture which you clear, and then you would be able to see the fracture reduction. So that is very important. Uh, Medial neurovascular should be saved by retracting them with FHL. We should be sure and we should be watchful that we should not be slipping PITFL. Exposure of the fracture fragment is from medial to lateral, from up to down, and fracture interdigitations will guide you for the reduction and dorsiflexion as the reduction maneuver. Reduce the fibula, it helps in reduction of posterior malleolus, temporarily fix it, that's what I do with 1 or 2 KYs. Then I reduce posterior malleolus, fix it temporarily, then fix posterior malleolus, and then fibula, so that it doesn't obscure your radiological assessment. In the cases where you have combination, we want to gain the length of fibula, so we do fibular fixation first and then posterior malleolus. So these are some clinical intraoperative pictures. Lateral position, one window. This is a posterior malleolus plate. This is second window, lateral plate. Okay. So anybody, this double density or sparse end or a flex end, what is it? Anybody?
That is the part of the posterior malleolus, sir.
Now, so you all knew that
Postromedial.
this is called double density sign or double
Yes, sir.
malleolus sign or a flag sign. So when you
Yes,
feel
sir.
that there is like a double medial malleolus, this is definitely a posteromedial variety of posterior malleolar fracture. And this is how you would see. And how do you approach posteromedial variety of posterior malleolus? You could do it in a supine position with external rotation with figure of 4, or you could do it in a prone, and you're going between posterior border of tibia and tendo Achilles. You, as far as possible, should not open the sheath of TP, or if at all, and inadvertently it gets open, you should be suturing back. There are various windows going between TP, tibialis posterior and FDL, FHL and neurovascular, or you could go between tibialis posterior and FDL on one side, FHL and neurovascular on other side. Windows, as per the nature of the fracture, you fix it temporarily, go back to the lateral side, fix it, and come back and fix medial side. Something like this. Small plate or anteroposterior screws. You should be watchful that your implants do not irritate tibialis posterior. It should not be in a groove. And this is what I wanted to talk today. A modified posteromedial approach. And this approach, if you see this, if you follow this green line, where go just by the side of tendo Achilles, and then you reflect the flexor hallucis longus on the lateral side and the neurovasculars and tibialis posterior and FDL on a medial side. And when you retract both the this thing, I like to put in some temporary K wires which would retract these muscles and neurovasculars and keep them away. The whole posterior part of fibula of tibia would be exposed. So again, this was another article which showed that this is the kind of exposure you get with modified posteromedial approach. And the same article said that posterolateral you will have this green zone is where you would be easily able to see that, but the modified posteromedial approach you would be able to see most of the lower part of the tibia. So this again is through one of the article that you put in medial and the lateral plate through this modified posteromedial approach. Yeah, this is
So
the
modified
case.
postromedial approach you do in prone.
Yes, absolutely in prone. You cannot do it in a lateral position.
And when do you prefer to do posterolateral approach in prone?
No, I posterolateral approach I do in the lateral position,
Okay.
into the lateral position, so that
Getting
you
the
remove the
length
bump,
exposed to
and you can make patient supine.
Can we address the
I
fibula
think
fracture also through this modified posteromedial approach, sir?
Posterior, you would be able to reach up to the posterior part of fibula. So you can definitely approach it.
Okay.
Definitely. So this is the picture from that article. They have approached it with only single approach. Yeah, you cannot fix the medial malus through it. Maybe you might have to use some clamp from outside and reduce. But yes, these two plates, even this third plate, posterior plate for the fibula, you can put it through modified posteromedial approach. Again, this is the kind of fracture geometry, completely shattered comminuted variety, and front plus back fixation, retrolateral plate with the direct lateral approach, medial fixation with a small plate, fibular fixation, and posterior fixation was done with modified posteromedial approach. So it's a beautiful approach. It gives you complete exposure and you have everything in front of you. Only thing, on one side there are neurovasculars. So it is better that if you can put in a temporary K wire, and with that K wire you retract the neurovasculars. You band the K wire, and band K wire would retract the neurovascular side. So
Sir, in
the
that
body
previous
first,
case, sorry, sir. What would be the sequence? The patient would be supine first, and then
no, patient will be prone first. All
yeah.
posterior variety of injuries. If you are dealing with the pilon or if you are dealing with the ankle, you have to stabilize the posterior aspect first, because most often than not in pilon you are building your reduction over that posterior part. So posterior medial approach is done in a prone position. Posterolateral is done in a lateral position, but this approach is always first followed by your fibula and tibia.
Okay, sir. So the anterolateral approach again, you turn the patient.
Yes, patient is to be done.
Okay, okay.
Now, some people do everything in the prone position where they bend the knee and fix the medial malleus in a prone position.
Oh, okay,
So,
sir.
yeah, but I mean, that is something where you have to get attuned to see everything in a reverse manner. So, I have not been doing that. I put my patient into the prone position and then turn, or I put in patient into the lateral position and then turn back. Uh, PDF or video of modified posteromedial approach. Okay, so I will do it. The case which I showed you and I posted in our group, and I was asking about that what all are the problems. So a female patient, and I had shown that case through the uh, video shooting. So there I did the osteotomy of the posterior malleus. It was a malunion. I did the osteotomy of fibula, and that that's where I use the modified posteromedial approach. But now, if I have such a case, I'll take the pictures or a video. But yes, we have time and we should be able to see it. Okay. So this already I have demonstrated that you want to see the posterior malleus. This is the way you see the posterior malleus limb into 45 to 50 degree of axial rotation, and a lateral view into that will delineate the posterior malleus. And this is the video. I think I have shown you into the intraoperative radiology talk. Okay, so some two good cases which I could pull out. Uh, uh, Case one is like a male, 24 years, with motor vehicular accident. So with this X-rays, and this is the kind of fixation which was done. Any comments onto this?
So the syndesmotic joint is not reduced properly.
Hmm.
Medial clear space is also increased.
And are you
There is
happy
an
with
impaction
this?
there,
Are
the
yes,
middle corner. Yes.
yes. Uh,
It's,
so yeah. So this patient came for suture removal, and this is how it was fixed. So what would you do? Would you accept this or would you revise, Dr. Balu?
Yes, I think the syndesmosis looks unreduced. So we'll definitely have to reduce.
Anything about the length of fibula? Are you happy with the length of fibula?
No, sir.
I think it's short.
No,
I
sir.
think the dime sign is not round. So
So you would revise, right?
yes, sir.
Yes,
So
sir.
this is how the CT looks. Syndesmosis not reduced. And what is this? Anybody?
Haylog's Chaput fracture.
Yes.
So part.
Yes. So
It's a
when you fix this, you may not need syndesmotic fixes. But then this has to be fixed uh, with the screws, with the washer, screws and washers, or sometimes you can put in a plate. So antegrade plate for chaput fragment, fibula lengthening, and the area was packed with the graft. We are going to discuss malunion of ankle. But this is just one case. And someone was asking me about, gaining the length. So if you want to gain the length, you put in the screws into the distal fragment, put one screw which is outside the plate, and then put in your AO compression distraction assembly or a laminar spreader or an interment and distract this. So plate is fixed to the distal fragment and you're temporarily holding it with a bone clamp which is held very loose, and then from here you distract, so you get the length, and then the area which is remaining you fill with the bone graft. So this is how you do the fibular lengthening. If there is an issue of rotation of the fibula, you may put this plate more posteriorly into the axial rotation and then change it to the uh, internal rotation.
So the Chaput fragment is access to the same incision.
Yes, yes, same
And
incision. Yeah.
only screw will do the work, or plating is recommended.
Mostly screw will do the work. Unless it is a big fragment, you have to put in a plate. Otherwise, screw would work well. I have put in a screws plus sometimes I have put in a internal brace. So 4.75 knotless anchor here. You can see my uh, highlighter here, and one knotless anchor of 3.5 here, and internal brace at tape, fiber tape between two. But by and large, if you fix, so for stiffened ramel, this is a anterior malleolus. So if you fix it, you don't really need to fix this syndesmosis. So that is the message this case is giving. That once you fix this, you don't need to fix this syndesmosis. Again, poor X-rays, but again he presented for suture removal, and this is the fixation. Comments, staple removal, he came for the staple removal. Comments on this X-ray, please.
So the
Anatomical fibular plate.
posterior
I'm sorry.
the posterior malleolus is also not fixed here.
And
Fibula plate is short. Fibula
yes,
plate is short.
Fibula length is not.
And syndesmosis
is wide.
Syndesmotic is medial
and
medial
here,
clear space is increased.
medial clear space.
yeah. So again, you may not really accept it. This again, fibular shortening here and malreduction, and if you see the fibula is like not proper into the sagittal kind of fixation. Here you see the gap, syndesmosis, and this also is not proper. So malreduction of fibula, which is fixed into the extension, comminuted fracture at chaput level, and malreduction of medial malleus. So what would you do? Just 10 days, 12, 10, 12 days. Yeah.
Revise, sir.
Revise. So how?
Revise.
Again, push-pull technique uh, for the fibula to get the length
Open
back.
reduction.
Syndesmosis you will fix or not?
Sir, on a different note, sir, here I think the plate on the posterior aspect of fibula would be better since the fracture line is in the sagittal plane.
See,
Fixation of the posterior malleus.
yeah, posterior plate. Yes, you have a go where you can have few screws here. You may use a posterior plate, but I mean again, lateral plate is not that bad in this case. It is mal reduced. Otherwise, lateral plate would also work.
Okay, sir.
And as
So,
somebody
any
was asking,
criteria to access the fibular length intraoperatively with SIAM, any landmark?
oh, that's a very good question. So for all, I mean, you may or may not follow this, but this is what after misfiring so many cases, I have started doing it. Number one, lateral X-ray of the opposite side is always on my view box. Number two, I paint and drape both the lower limbs. Whenever it's a trimalleolar fracture, I drape both the limbs. And in my next talk onto syndesmosis, I'm going to come up with how I do my syndesmotic surgery. But if you drape both the lower limbs with your patella exposed, you can definitely see and manage the perfect rotations of both the limbs when you're seeing the image. So that makes your life absolutely easy. So seeing at the parameters like talus crural angle, like a dime sign, like a clear space, tibiofibular or medial clear space, or a tibiofibular overlap, all these things you need to compare with the opposite side. And you know, when you are dealing with a malunited fibular fracture or malunited ankle fracture, what is the investigation? Anybody? If you are asked to get only one investigation to treat malunited ankle fracture, which investigation would you get?
CT scan.
It's bilateral axial comparative CT scan. I'll go personally to the CT scan, or my fellow would go to the CT scan, would position limb into equal amount of rotation, and you get bilateral axial CT scan at the level of the ankle joint. You will see the incisura, you will see the fibula, you will see whether the fibula has gone up or down, where is your screw line, everything. So whenever you're thinking to revise any ankle fracture, the single most important investigation is bilateral axial CT scan, comparative CT scan, where your radiologist must make sure that he is putting foot and ankle into the same degree of rotation. So, okay, comminuted chaput fragment, mal-reduced medial malleus, posterior malleus was not addressed. So everything requires to be addressed. But then this was the problem. Existing approaches were there. Lateral malleus was like mal-reduced. It was a mal-union machine. Nor chaput, nor EITFL, PITFL were addressed. And medial malleus fracture was malunion. Into malunion. So first stage into the supine, all the implants were removed. Fragments were removed, fixation of medial malleus with small fragments to fixation of lateral malleus with restoration of the length with an anterior plate. You can see it here. And then in the stage 2, modified posteromedial approach, bone fragment that was parked in the lateral incision was pushed into the plate through this approach and fixed flushed with K-wire, as Professor Deshpande said, and then this is how this K-wire was put. The displaced fragment was pushed back through the posteromedial approach, and medial malleus was also fixed. So this is how the whole fixation happened, and then it went on to heal. So the message from these two cases is Chaput fragment is very important. Posterior malleus is to be fixed by posterior approach, and syndesmotic screw is to be avoided if will automatically get avoided if you fix the Chaput fragment. Now, uh, how far can posterior plate be put on posterior exposure can be done in posterolateral approach. Yes. So as you go up into the posterolateral exposure, you would encounter your uh, neurovascular tough, uh, thick, muscle masses, and you will find it to retract them very, very difficult. So uh, I mean, I do not know of any centimeter or so, but yes, if you want to go with a posterior plate you um, into the area which is above the lower third, then you will have to be watchful. Sometimes we are forced to do that when you have a comminuted pilon variety of fracture, where the fracture of the posterior part is also extending upwards. You may have to slide the plate, but you should be very, very much watchful by in doing it. As said, there is no limit on to doing it, but yes, as you go up, the space gets closed and the more and more muscle masses come in your way. How often can we miss Chaput fracture? As in both the cases, in X-ray, entire fragment was not clear. Yeah. So I think Chaput fragment is quite commonly missed. And if you follow Stephen Ramel's algorithm, that he looks at medial malleus, lateral malleus, anterior malleus, and posterior malleus. So he looks at four malleolus. Any ankle fracture, different views, he tries to locate four malleolus: anterior malleus, medial malleus, posterior malleus, and lateral malleus. And so if you have an habit of looking at Chaput fragment, finding out the Chaput fragment, you would not miss it. Well, anyway, so far as I am concerned, I do open reduction of syndesmosis. So when I do the open reduction of the syndesmosis, I see the syndesmosis, and so if there is a Chaput fragment, I definitely locate it. If there is a waxed up fragment, I also locate it and I fix it. And I make sure that I fix it perfectly. So it is like if your mind has an idea, your eyes would be seeing it. Your mind uh, eyes would not see anything which your mind have no idea about.
So any special view to locate chaput fragment? Sometimes patients come with twisting injury and they have isolated chaput fractures that need to be fixed or conservative only.
No, I think it's very important to really deal with the chaput fragment uh, well in time, perfectly, because if not, then it can really spoil your fixation, and the syndesmotic ligaments, strong ligaments are attached to it, so it requires a stable solid fixation.
So if there is only isolated chaput fracture, then
Then I think you can take a small anterolateral approach and you can fix it, because its fixation is required, because it's like avulsion of the ligament. So all avulsion of the ligaments, medial, lateral, chaput, they require fixation, because if you don't fix the avulsed ligament, uh, definitely it could go haywire.
so fixation with screw only.
Yeah, fixation with the screw. Sometimes it's if it is an avulsed fragment, you cannot really fix it. You can use a washer and the screw fixation. I've used suture anchor if I'm not able to repair it, and sometimes I've augmented with a internal brace or artificial tape. Uh, there is a question that how to approach open syndesmotic repair when we are using posterolateral approach. So it's simple. If you have taken a posterolateral approach, uh, you're using a floppy lateral position. So with that, you just turn your limb outwards, and you put in a small 3 centimeter, 2 to 3 centimeter incision at the anterolateral aspect of the ankle. So that incision and your posterolateral approach is having a distance of at least your 3 to 4 finger, and when the size of that incision is small in comparison to posterolateral approach. So you're not really worried about a breach and the tissue problem. So put in a small incision, have a look at the syndesmosis, do all your manipulations and also have a direct look onto the syndesmosis. For your anterolateral approach, you want to see the syndesmosis, you can definitely put in an incision little down which can curve anteriorly, and you reflect the soft tissues and you would be able to see the syndesmotic area. It's not that difficult with anterolateral approach. With posterolateral approach, you have to take a small approach, which would be an extra approach uh, together with your posterolateral approach. And now comes the most controversial. Yeah, anything anybody wants to ask into this?
Hello, sir. Just one question, sir. When we're taking multiple approaches in the foot and ankle area, what is your protocol for avoiding wound dehiscence or anything that you would add to promote wound healing?
So, number one, when your approaches are more than 3 in ankle, make sure that one of the approach should be minimally invasive. So even if
Okay.
you are taking 3 approach, if you can have one approach which is MIS, minimally invasive, it would be helpful. So that's number one. Number two, that the length between length of X incision with length of Y incision, sometimes you may not be able to maintain the bridge of forefinger, which typically say. Then if the length of one incision is half the length of other incision, you're sure that you're not going to get any skin issues. So this
Okay.
is what plastic surgeons say, and plastic surgery book says that if you're not able to maintain that forefinger distance between two incisions, make sure that one incision out of two is half the size of a longer incision. If it
Yes.
exceeds the half the size of the longer incision, then there could be skin issue. I think I have made it clear. Is that
Yes.
clear? Yeah.
Yes, sir.
And the third thing which I do, and this is what I am doing for foot incisions, and that when we talk about Lisprank, I'll I'll be telling you and I'll be showing you, because what happens that when you have a Lisprank 1, 2, and 3, or 1, 2, 3, 4, 5, you really, even in spite of you waiting for 10 days, 15 days after wrinkle also, for you to maintain the distance of forefinger between two incisions, and more so in our Indian females, is not possible.
Yes.
Is not possible. So what do you do? You need to dilate your incision proximally, because the blood supply, the angiosome in the foot fall starts from the proximal and comes to the distal.
Yes.
So distally you may have to go closer, but proximally you make your two incisions like a funnel.
Yes.
You're seeing my hands
Yes, sir. Yes, sir.
through the camera. So
Yes, sir.
funnel out your incision. So these two, three things are the trick. And the last part is that when your incisions, with your incisions, you're not able to maintain that distance which has been said into the literature, don't undermine your approaches.
Yes.
Go straight. If you undermine these approaches, then there could be problem of soft tissue healing, and you would find problem. So I think I have been able to clarify about this safe distance between two incisions.
Yes,
Would
sir.
you
Yes,
opt
sir.
for WAC or pico dressing over the suture wounds to promote wound healing and about? And not really, unless that I'm not able to close, or unless the closure is in such tension that the in between the sutures the wound is opening up, you may think of putting a vac. Otherwise, vac, it is to be used, and I use it for wound which I am not able to close, or for the wound or defect which I want to be filled with the granulation tissue. So this was a talk which I was asked to give in Asia Pacific Foot and Ankle Council's Advanced Foot and Ankle course, and majority of the students is into this talk. So we all know that syndesmotic ligament, it is AITFL, anterior inferior tibiofibular ligament, posterior inferior tibiofibular ligament, and interosseous membrane as one of the part. And I don't want to go into the anatomy of this, but the most important thing is that AITFL contributes to 33% stability of syndesmosis. PITFL contributes to 35% and introsseous membrane 22%. So when you have a syndesmotic injury, you have this AITFL torn and IOL torn, introsseous membrane torn. So you lose 55% of the stability. A PITFL is very rarely torn, but if it is torn with a small fragment, then you lose a lot of syndesmotic stability. Okay, blood supply. Okay, we know this. I will rush through. You know the injury mechanics, but you know, when you have a doubt about a patient coming to you with a ligament injury or pure ligament injury you want to rule out, you should ask for a mechanism of injury. And a very important question, could you walk after the injury? If patient was not able to walk after injury, that means that ligament injury was very severe, or ligament injury was associated with bone injury also. Where is the pain located? Whether there is pain on weight bearing, sometimes the syndesmotic sprain. Patient would come with the complaint of pain on weight bearing at the level of syndesmotic ligament. They also feel unstable, and obviously treatments taken, prior surgery is done. And how do you diagnose this syndesmotic injury? You have a swelling, a chymosis, you have a local tenderness, patient say that there is inability to bear weight, and patient has got reduced passive dorsiflexion. This test I am going to show you. Okay, so for syndesmosis, we are going to discuss diagnosis of the syndesmosis, then intraoperative diagnosis of syndesmosis. These two things are very important. So the first test we all know is a squeeze test. So when you squeeze tibia and fibula at the mid calf of the injured leg, on compression there is pain at the syndesmotic area. Now this is not so sensitive, no specific, and nobody uses this test, but this is the important test. External rotation test. You're holding foot into 90 degree of or 90 degree or little dorsiflexion, holding the leg in one hand, and you are external. This is the diagnostic test. I am running this video again. So 90 degree, patient's limb is suspended, examiner is sitting on a low stool, and this is the external rotation stress test, one of the highly sensitive and specific tests. Clear? This is a cross leg test. This is also very important. Again, very sensitive test. So you ask your patient to put in the leg. The fibula and tibia is put over the lower third of the thigh, and they get compressed with each other. And on cross leg sitting, there is a pain generated here. That is called cross leg test. And this is the forced dorsiflexion test I was mentioning. You ask patient to relax and you do forcible dorsiflexion. On forcible dorsiflexion, when you have pain, that means you have your tibia and fibula compressed together, and this generates a pain. And the last test is your Cotton's test. That there is also a cotton test which you do uh, in like you do the other test, like you do intraoperative test, you can also do Cotton's test here. Now, what all X-rays you get for the syndesmosis? EP lateral mortise view of ankle, full length view of the affected leg to rule out the Masonia's injury, and then look at the radiographic signs of the ankle. We have discussed this: tibiofibular overlap, tibiofibular clear space, medial clear space, talocrural angle, and dime or other sign. The tibiofibular overlap, this was shown by Dr. Anish Kadakia through various cross-sectional study, that in many cases the tibiofibular overlap is is not there and patient is not having any trauma. So tibiofibular overlap is a poor sign for us to consider as syndesmotic sign. It is a tibiofibular clear space, which is best modality to just know the syndesmotic instability. You compare it with the opposite side, mortise tibiofibular clear space. This is the most useful sign as noted by this study by Dr. Kadakia in 2016. So don't rely on tibiofibular overlap, but rely on tibiofibular clear space. It is there as a good, reliable indicator in every view. Stress radiography you do in external rotation and evaluate all the views, AP, lateral and mortise. So there would be the lateral displacement of fibula and talus. There would be posterior displacement of the fibula, and gravity stress view, there would be opening. You all know this. Now, this is the question of the day. Do you need radiography of only affected limb? And the answer is no. This study came up and said that the normal coronal syndesmotic alignment is not predictable. You need to assess contralateral lateral view of the limb. So this is why I drape both the limbs and I put in the lateral view of the opposite side on view box, because a normal radiography is very important to diagnose syndesmotic problem. So stress examination, contralateral examination and dynamic fluoro examinations are invariable for pre-operative syndesmotic injury diagnosis. Okay, this one study by Chen et al. They said that the anterior distance in the notch, where the fibula is in the notch of the tibia, at the level of incisura, anterior distance is 4 mm, middle distance is 4 mm, and posterior distance is 5.7. But this is not reliable. This can vary. So that is why you should always have the opposite side CT scan showing you the perfect delineation of this notch. This was one more sign. They said that anterolateral fibula to anterior tubercle of tibia, if you draw a line that falls within 2 mm from anterior surface of tibia, this is done 1 centimeter above the level of ankle. I have not found this sign useful, so we don't discuss it. Okay, now this is what most of the advanced center in the world do, and they have either O-arm or intraoperative CT scan, where once they reduce the syndesmosis, they fix it with the K wires, temporary fixation of the syndesmosis, and then patient is sent into the CT scan gantry, and CT scan is taken, and then they make sure that the reduction is proper. And now, for pre-operative diagnosis of syndesmotic injury world over, such kind of weight-bearing CT scans are available, and that is an advanced diagnostic tool, very vital to diagnose syndesmotic injury. So this is how on a weight-bearing CT scan you can see that the space here is distorted, which is the space on the affected side. MRI is also highly sensitive and specific. Pure ligamentous injury, OCD talus, associated tendonitis, all you can see in MRI. So these are some MRI images. Now, intraoperative no, this was the preoperative clinical diagnosis of syndesmosis. But more than that, for us, we are concerned with intraoperative diagnosis of syndesmosis. So you can put in a hook on the medial aspect of the fibula after you fix the fibula and pull the fibula laterally and take the image and see whether there is dilatation or opening of ear or not. Then external rotation test, you hold the leg and rotate the foot externally and take AP and oblique image. So that is second intraoperative test. Now are you aware about this test, tap test? Anybody?
Yes, sir.
Yeah. So what you do, Prabnur?
We drill it and then we put the tap and try to push the tibia away, and it can open up the medial clear space.
So it's a blunt tap, which you go on tightening, and tap is not going to go through the tibia, and it is going to pull the tibia and fibula apart, and this can give you the diagnosis of syndesmotic instability. And then modified Cotton's test, where you are pulling fibula posteriorly and taking a lateral image. And the last but not the least is ballotment test. It was observed by various workers that the mediolateral instability is less vis-a-vis the anteroposterior instability in a syndesmotic injury. So you should be not forgetting to do this. And now somebody was wanting video. So I'm going to show it in a video that how do you document intraoperative. Now look, this is a Cotton's test. Are you all able to see? I have put in, now this is my posterolateral approach, and this is a small anterolateral approach through which I am visualizing the syndesmosis. Syndesmosis already ligaments are torn, and this is modified Cotton's test. Clear? So it automatically shows you the video of anterolateral exposure to see the syndesmosis. Someone.
This is after fixing the fibula, sir.
Yeah, this is after fixing the fibula. And ballotment test. See, I have fixed the fibula. And yeah, this is ballotment. This is more important, anteroposterior rocking. And then diagnostic arthroscopy is also a very good modality where what they call is a drive-through sign. So you are able to put in your probe or shaver between the medial malleolus and the talus. So this, when is able to go in, 3 mm probe is when it is able to go in and opens. If it is able to go in, that means syndesmosis is unstable. And when you fix the syndesmosis, when you are not able to put the probe inside, that means you have reduced the syndesmosis. So how wide is too wide? It is 3 mm. This study said that open is better than the closed. Seeing is believing. So nowadays, if you are not a routine arthroscopist, you open the syndesmosis and do open reduction and open fixation. That is the best thing. So the commandments, don't rely on level of fibular fracture. It can cheat you. Even Weber B fractures, that 40% of the Weber B fractures, they have syndesmotic injury. Don't rule it out if injury X-rays are negative. And stress every ankle fracture intraoperatively. These are the commandments to diagnose syndesmotic injury efficiently. And then other commandments are intraoperative test, opposite side lateral view, open reduction, and arthroscopy. So these are the messages with regards to diagnosis of syndesmotic injury. And we know that it could be with or without fracture. Now, if it is without fracture, it can mimic ankle sprain. You should have high index of suspicion. Grade 1 is mild sprain, which is treated conservatively. Grade 2, where you have some diastasis, if it is stable, you can go ahead and give conservative care, but some instability, you need surgery. And grade 3, there is instability with complete ligament disruption, which requires surgery. So management, purely ligamentous injury, grade 1, you can tape, you can give boot, non-weight bearing for 4 to 6 weeks, and patient should do well. But when there is diastasis, fibula and tibia are separated without bony injury, that is syndesmotic injury, which is stage 3, type 3. It requires fixation, 4-hole plate, 2 screws or tightrope and screw fixation through the plate. As somebody was saying, you're using the last 2 holes of the plate and leaving the upper 2 holes. 2-hole plate can also be used like shown in this case. Now, syndesmotic injury, how do you do open reduction? Small 3 centimeter wound on an anterolateral aspect of the ankle, and you can open the syndesmosis. You can see the disrupted syndesmosis, and you can do all your tests. But this is what was the message given by Paul Tornetta, that check every fracture to rule out association of syndesmotic injury. And reduction is the single most important parameter. Multiple studies said that it is the single most important parameter. Reduction, reduction, and reduction. So, if it is poorly reduced, that means the outcome would be poor. Now, what all are the causes of malreduction? Malreduction is what we are going. You can stop me at any time. So, what all are the causes of malreduction? Anybody? And how can we negate? How can we reduce the rate of malreduction?
Sir, overcompression of the syndesmosis.
Perfect. So overcompression of syndesmosis. Now, before that, if we go stage wise, the morphology of incisura is different in different patients. So if you do not have pre-operative bilateral axial CT scan, you really do not, you're not able to compare the morphology of incisura. But incisura sometimes could be flat, sometimes it could be concave, even sometimes it was found to be convex. So variable incisura morphology could be the reason for malreduction. So what is the remedy for that? Don't look at the incisura for joint reduction. You look at the joint line for your reduction of syndesmosis. It is the presence of Mercedes-Benz sign in an oblique view, which is going to tell you that yes, this syndesmosis is nicely reduced. So look at the joint line for your reduction. It is there in front of you. You just go and need to go a little down. Look at the joint. You should be able to see tibia, fibula, and uh, talus, and see your reduction. How is it come? So if you do not rely on looking at your reduction at incisura and go little down at the level of joint, you would be able to prevent malreduction. So that is the first thing. Then somebody said that over compression or the compression in a wrong manner. So when you are using a clamp, if the clamp is not put into the proper axis, into the axis into which you fix the syndesmotic screw posterolateral to anteromedial, you may under reduce, over compress, under compress, or slide fibula anteriorly or posteriorly. So your clamp could give a wrong vector, and the remedy to this is, and these are various studies which have shown that the clamp could give malreduction. So remedy is not to use a clamp, but just use a finger reduction. So unless it's a malunited case, unless it's a case which is old case, I don't use clamp. In a fresh case, I like to use finger reduction. Only finger reduction, no clamp. So if at all you want to position the clamp, a clamp has to be positioned in such a manner that posterolateral to anterior medial, the direction into which you are passing the screw should be the direction where a clamp should be there. And then this study said that clamp should be into the anterior third, medial side should be on anterior third of the lateral aspect of the tibia, so that you are positioning it from posterolateral to anteromedial. Now, how not to overcompress? As somebody said that it could be overcompressed. If you want not to overcompress it, you have to calculate the adequate compression force. And what is that adequate compression force? Study said that 130 Newton is the adequate compression force. Now, how do you quantify this 130 Newton force in a real life situation? So, when you are operating, how do you make sure that the force or the compression force which you are giving to syndesmosis is 130 Newton? So this study also showed that it is like compressing a empty Coke, compressing a full Coke or Pepsi tin. So how much are you able to compress a full tin of the Coke or Pepsi or Thumbs Up? The force which you exert to compress it is the same force they compared as 130 Newton. So this is how you prevent over compression of syndesmosis. If you over compress, then there could be a fibular malreduction.
Sir, if we dorsiflex the ankle and the talar dome comes in, can it prevent the overcompression?
Not really. Uh, Still you could over compress if you are using a clamp. So the best thing is to use your finger compression with the finger and thumb in the all fresh cases, and you are able to really compress it and bring it nicely to the normal reduction. Now, for fibular malreduction, if you really look at the dime sign, you look at the talocrural angle, and sometimes you need this push-pull screw, then you are able to prevent fibular malreduction and thereby syndesmotic malreduction. Syndesmotic malreduction, again you want to prevent, you do open reduction. Now, can you see this? This is my posterolateral approach, and this is the fibula drawn, and I've gone about 3 centimeter onto the anterior border of the fibula. This is the typical incision for open reduction of syndesmosis. I think somebody wanted a video of this, but this is how you put in a incision, and then just the skin and subcutaneous tissue is cut in the fascia, and then immediately you are seeing the syndesmotic ligament, and you can always do your test and make sure that ligament is intact. So if you want to prevent fibular malreduction and thereby syndesmotic malreduction, remedy is to image normal ankle. Where is the fibula lying after reduction? Fibula normally lies into the posterior two-third of the ankle in a sagittal image. You need to learn to take true talar dome lateral, so you can compare posterior malleus profile. As I said, this article also said in 2013 that you learn to take true talar dome lateral, or the lateral view in such a manner that you completely see the posterior malleus morphology. Fibular malreduction you can also prevent by looking at the lateral X-ray of the normal side in the in the OR. You also can prevent it by preparing both the limbs, as shown in this picture. They say that you put in a curved osteotomy flush to the fibula at open reduction, and this curved osteotomy when you put at which traverses flush to the fibular surface, it would definitely mean that okay, if it is touching the tibia, the fibula is not malreduced into syndesmosis. And drive-through sign, as I said in arthroscopy, will tell you that will help you to prevent malreduction of syndesmosis. And this OARM or intraoperative CT scan would also help you to prevent syndesmotic malunion. So that is why people over and above fluoro do arthroscopy, over and above they do CT scan intraoperatively or O-arm intraoperatively. Now there was a question 3.5 screw, 4.5 screw. There are too many choices. You have to select what is the remedy. Go back to the literature. So what literature has said is what we have to accept and we have to move forward. So literature said that one screw, two screw, three cortices, four cortices, there is no difference. Except in a severe injury, you put in a two screws which go four cortices. Very osteoporotic case, you use four cortices, two screws, and delayed presentations, late reconstructions, you use two screws, four cortices or three cortices. So late present, now this is, look at this. This is the late presented Weber 2, Weber C kind of a patient case where I've done a syndesmotic fixation. This time again, no plate was used, but this is not the ideal one which I've done. Now, this is the ideal one, plate. Some vertically unstable injury. So Masonier injury, someone was asking. So this is how I put in a plate and two syndesmotic screw. So otherwise, the three cortices, four cortices, one screw or two screw doesn't matter, except in such kind of situation where there is a grave injury or late presentation, you want to put in two screws. Should we remove the screws or not? When? I think no much literature to support or literature to support both removal or retaining. But some studies showed that removal of the screw gave better movements. Some studies showed that removal of the screw gave way and syndesmosis opened out. So there are studies supporting both. So far as what I am doing, I will come back at the end of this presentation. But this is what is I follow in my practice. If at 4 months my patient's dorsiflexion is restricted, that means I have tightened syndesmotic screw more than required, I go back, I remove the screw, not otherwise. Okay, we all know posterolateral to anteromedial. This is also important. Rest your ankle over a towel bump, not the heel. So don't do this, do this. Okay, whether to use screw or suture button, again evidence is in favor of both. Very recent studies they showed that the suture button is slightly better in outcome than the screw because it may not need removal. So screw in my practice, routine cases I like to use suture button. Settled injuries I like to use suture button. I have not used the two suture buttons for better stability. But screws for the delayed presentation, osteoporosis, severe injury, and vertically unstable fracture injury, I like to use screws. Addition of tape is what being done by the people. I have not done it routinely unless there is a very bad wax stuff or a chaput fragment fracture. People have also started doing the repair of the AITFL and putting in brace. I've done it in one or two cases, not otherwise. And then Synthes has come up with a new implant where it is screw plus tightrope both. Are you people, anybody is aware about this Fibulink? It is not introduced in India. It's going to be introduced in India very shortly.
No, sir.
So Fibulink is like a device where you have a threaded tibia anchor, fixed length suture bridge. Herein you have a tightrope and telescoping fibular anchor which is put in through the plate or outside the plate with or without washer. You don't need a medial incision, only lateral incision. So there is a screw plus tightrope. Both combination is Fibulink which Synthes has made. So I do not know at the end of this talk whether I have convinced you or I have confused you. So how do it? I do it. So I drape both the sides. I put in the lateral view of opposite side on my view box. I always open reduced syndesmosis with a small 3 centimeter anterolateral incision. Many times, if I'm not sure, I do arthroscopy and I also check postoperatively with a scope. I like to do thumb reduction, then the clamp, except the old cases where I'll use clamp, otherwise not. I fix 2 K-wires. Now look at this. This is what I'm doing. I put in anterior blocking wire over and above syndesmotic fixation wire. So when you're going from posterolateral to anteromedial, there is a tendency of fibula to slide anterior. So I put in an anterior blocking wire and I put in a syndesmosis fixation wire. So these 2 wires and then my syndesmosis go ahead and fix. I fix it. Been using tight rope and on a medial side, once I do everything, I uh, also stress on the medial side. If required, I do the deltoid ligament. Look at this. So here is the instability of the deltoid and I'll definitely repair the deltoid in such cases with and in all old cases or in cases where I have problem, I do take postoperative CT scan to make sure whether I've reduced it nicely or not. Loss of reduction, you will have to go in and do it again. And while you do it, you have to clear the syndesmosis with the fibrosis and do it again. Missed or chronic syndesmotic injury, you have various choices, syndesmotic debridement and screw fixation, which is mostly not sufficient. So to repair and put in a screw fixation, you can reconstruct and put in a screw fixation. You can do bone block transfer and screw fixation. You can do syndesmotic fusion. So delayed syndesmotic injury, delayed presentation. If you have a diagnosis of this early, if it is not early diagnosed, then you have to go for syndesmotic reconstruction. If it is diagnosed early and fracture is well reduced, then you just have to go and do revision syndesmotic fixation. If it is fracture is not well reduced, you need to reduce the fracture and do syndesmotic reduction. If there is a late diagnosis, like you diagnose it by 4 months, 6 months, 9 months, and already ankle osteoarthritic changes are there, then you may go for syndesmotic reconstruction plus or minus total ankle replacement or ankle fusion. If ankle osteoarthritic changes are not there by end of 6 or 9 months when your patient comes to you with syndesmotic malunion, you go for syndesmotic fusion plus fibular lengthening. So I'm going to answer a lot of questions and I'm sure there may be many more into the syndesmotic. It's one of the very controversial area and it is the area where we misfire a lot. Can we do secondary closure after 3 to 4 days? Definitely you can do any role of single close postoperative steroid to reduce. No, I don't use steroid at all. In lateral approach to distal fibula plating, whether to keep incision anterior or posterior. Oh, that's a good question. So if you want to go to syndesmosis through that same approach, you have to take a little longer incision and distally take your incision anteriorly so that you are able to reach to the syndesmosis. Do you prefer single syndesmotic screw or double screw? Size of the screw 3.5 is the screw. I prefer 3 cortices and if possible, if my patient is affording, I prefer tight rope. What to do 3 cortices fixation and when to do 4. So I already told you that when you have a very osteoporotic situation, when you have a very severe injury, when you have a late presentation, then 4 cortices double screw fixation would be ideal. How often do you do open induction of syndrome? Do you only do chronic case? No, I think as I said, I do open induction each and every case. Which screw do you use? Okay, cannulate screw or manual? No, I don't use cannulate screw nor I use a manual screw. I use a 3.5 cortex screw. So almost all the questions in chat box addressed. Now, any questions you have with regards to syndesmotic fixation, we can take it.
Excuse me, sir.
At what height from
Sir, you
ankle joint
mentioned.
should I fix the screw? So 2.5 to 4.5. Any studies that controversy is resolved. 2.5 to 4.5 from the ankle mortise, above the ankle mortise is the area into which you should be putting a syndesmotic screw. Ankle position while inserting syndesmotic, it doesn't matter. You just allow ankle to fall into the normal natural position. It sorry. It was a notion beforehand. It has just gone away that there is no fixed position of the ankle while you are passing the syndesmotic screw. That controversy is clear.
Excuse me, sir.
Yes.
Sir, you mentioned earlier about the two screws for syndesmosis should be through the plate because if we are not using the plate, then we may create a fracture at that whenever we are putting the screws. Sir, is there any biomechanical reliability, like anything related to biomechanics of the fixation when we are using a plate with?
See, definitely when you're using screws through the plate, biomechanically it is a sound fixation, and that is what studies came up with. And 3.5 screw, when you drill it and when you pass it from the fibula, definitely it can create a sort of big biomechanically unsound, big lacuna or big stress riser into the fibula. And then you have two such screws when you're passing for a syndesmotic injury. There could be a crack continuing between two, and you can lose your fixus and you can get the fracture of the fibula. And that is why the fibular syndesmotic screw through the fibular plate is what preferred.
And sir, when should we go for a tightrope?
So now, very recent studies they have emphatically shown that tightrope by all means is better than the screw. So even AO, it was the AO group who were against tightrope and they were promoting the screws. They have also started talking about syndesmotic tightrope and they came up with this new device which is essentially a tightrope where instead of the thread there are screws threaded. So, by and large, for all acute injuries, um, use of tightrope would be justifiable because it is a biological fixation. If you tighten it more, then also it doesn't matter if you have sort of over tighten it. Really doesn't matter with tightrope. It will give way because it's a biological fixation. It will give some room for ankle to move or syndesmosis to open. So given a choice, tightrope would be the preferred modality of fixation. If it's an old case, if it's a severe injury, if it's a vertically unstable like Masonia type of injury, then I think you may like to put in screws through the plate. Otherwise, tightrope is good implant.
And sir, another question is like if we have an elderly patient, maybe 60 but not diabetic. So in diabetic, I've read that paper that we have to put more screws and fix the syndesmosis, maybe more cortices. So if there is an elderly patient, maybe above 60, and even if the syndesmosis is not opening, should we fix the syndesmosis in order to make the construct more stable?
No, no, it's not. See, the notion is that if you have a patient with diabetic neuropathy, you want everything to be double. So solid fixation, double fixation. So therein you use lot of fibula pro tibia screw. So not otherwise. Very rarely for an osteoporotic ankle fracture, If it is very osteoporotic, I've used 3-4 screws which go from fibula to tibia. So they are fibula pro tibia screws.
Thank you, sir.
Okay. So I guess I also wanted to deliberate onto special situations as well as diabetic ankle fractures, but maybe we'll take it some other time. This Sunday, we'll have a joint session on to talus fractures with Dr. Tanna's fellows. We'll be starting by 11 to 1:30. Any other question, query, or we say goodbye? Sorry for delay today. We should have covered the rest of the two
Excuse
topics
me,
also.
sir.
Please.
Yeah, I have come across situations where a chronic dislocation of fracture dislocation of the ankle, and then when you are trying to reduce intraoperatively, you get difficulties reducing the fibula, and sometimes you are forced to put the syndesmosis screw in a lag screw mode. So that you can get enough compression so that you can reduce the fibula well. Would you comment on that?
Yeah. So we have a presentation on two special conditions into ankle fractures. So there is a
Okay.
condition where you are not able to reduce fibular fracture. An unreducible fibular fracture in literature has come up as Bosworth. They're called as Bosworth fracture dislocation of fibula. So we're going to discuss that, where whatever you do, you may not be able to reduce, and then you have to go in and do open reduction on an emergency. So these cases are Bosworth fracture dislocation of ankle. So we'll discuss that in some special situation present, which I wanted to discuss today, but I think 11:30 my day gets over. Sorry about it. Today we
All right.
started late by half an hour, so that's why. But we'll cover that, please. So thank you everybody and good night.
Thank you, sir. Good night.
We'll see you all
Thank you, sir.
Good
on
night, sir.
Sunday.
Good night.
Thank you, sir. Good night, sir.
Good night, sir. Thank you, sir.
Good night, sir.
Yes, sir.